It wasn't long before I realized it's all failure. So all of those sessions that we did, it's just so powerful. You are constantly thinking about kidney, pancreatic islet beta cell, myocyte, alveolar. You're just thinking about those things in a way I did not before as a physician, not in as complete of a story as we talk about when we're teaching. It absolutely makes you a better doctor.
Well, it looks like a number of you have not yet subscribed to the channel. What we're trying to show you is that medicine is not a number of disconnected facts. It is a way of thinking about your patient. The more that you can start with your patient and have a story that runs through pathophysiology, the better you will perform in your exams and the more performance you'll get when you have to do your patient evaluations. So make sure to subscribe. Well, good morning, everyone. Today we have a special guest. This is a very old friend and a teaching colleague where we've been through all the wars together. And so it's my great pleasure to introduce to you Dr. Eric Nielson. Welcome, Eric.
Such a pleasure to be with you, Philip, as always.
Let's just talk about why this is a special guest. Eric was teaching the simulation lab at a Caribbean university when I was doing their STEP review course. And this was basically going through 8 systems and failure. And one day he just cruised in to see what the new guy was talking about and grabbed me afterwards and made me basically spend 2 hours teaching him my way of doing heart. And this is a trimester system. So every semester when I came back, we would spend an afternoon together and he would learn a new system. It's not like he didn't know it. I mean, he was teaching sim, but there's nothing like having someone walk through giving their thoughts about how they see it. And then every day he'd go to his sim lab with the students and he was using it. So he became more and more convinced how powerful this was. And then finally he'd been through all the systems and we got a contract to review that just was more than our thing. And I said to Eric, would you just do it? And he went, I'm ready to go. And so he actually started teaching the program himself. And 3 or 4 times later, voila, there were 2 of us. So that's a really good story. And I'll let Eric now pick it up with a story of how he's gone back and forth between private practice and teaching. And I'll sort of try to keep him online with some of the themes we're developing here and let her rip. So Eric, over to you.
Thanks so much, Philip. And again, it's always, so fun to hang out and talk. And
There's only 3 of us, right?
yeah, exactly. There are about 3 of us. Yeah, so, I've made this big transition sort of back to, majority clinical practice after teaching, pretty much exclusive teaching and teaching basic science for more than 10 years. It was sort of a personal / professional transition as most things are in life.
Didn't you actually come out of med school and go into practice?
I came out of med school and I practiced for about a year.
But you did a residency.
Yeah, oh yeah, oh yeah. Yeah. I did family medicine residency, and a component of that residency was global health tropical medicine. And I spent some time in sub-Saharan Africa, basically doing rotations and really wanting to incorporate that as part of my career.
Straight out of residency.
Yeah,
Well, that must have been a walk on the wild side.
that was very interesting and challenging for many reasons, amazingly rewarding.
What brought you back from that?
So a big component of that job, but it was with the Peace Corps. A big component of that job was teaching at a university. I thought it was going to be mostly seeing patients with the sort of needs. Obviously, there was a teaching component that was a big part of the program, but it turned into mostly teaching, and I just really liked it. It was really hard. I didn't really know what I was doing. I mean, you teach medical students and residents, through training, but you kind of just teach them what you know and what you were taught, and that's what you got. So I really started thinking about making teaching a big part of my career. And I basically went back to my medical school and taught for 10 years.
This was in the Caribbean.
Yeah, exactly. This is in the Caribbean.
Well, there's got to be a woman in there somewhere.
Yeah, as I say, I had an amazing mentor who you know.
She's been on the show. It's Nancy, right?
Oh, I've seen the show.
Nancy's been on twice, so yeah, you can actually say her by name.
I keep, this is one of my regular programming here,
For sure, me too.
One of my Sunday programs is, the YouTube. And yeah, it just became more and more of a passion and I was I was learning more and more. It became more and more challenging as I was diving deeper into the real skill of teaching, especially at the basic science level, where we're essentially taking, college students and really, trying to turn them into doctors and provide those foundational principles,
Yeah.
that are challenging.
What took you off Dominica?
Basically a hurricane, you know,
Yeah.
uh, as it can do. And then, we floated around a little bit. I taught at a couple schools.
Didn't you get married in there somewhere?
I did, yeah, and some personal,
Yeah,
you know,
that matters.
yeah, personal, kind of changes,
Yes,
advances in my life, and yeah, the whole, cycle of life or, whatever,
of course.
however you want to say that, and that, obviously that drives professional decisions as well. But I stuck with the teaching for about 10 years at a few different places and, both, on the mainland here, in the United States and also internationally.
And then you got the big offer from Nancy.
And then I got the big offer from Nancy to go back with that team.
So what made that offer so overwhelming? Because you and I discussed it before you took it, right? And I said, "Oh, this is to go work with Nancy under these conditions. That's a gotta do it." What did she promise you?
Number 1, working with Nancy, and having Nancy as sort of, the person in charge is not only personally, but even more important professionally
Remember how frustrated we were at that other med school?
for the purposes of our conversation. Having Nancy make decisions about what gets taught and how it gets taught and the way it's taught is night and day compared to the different experiences we've had, where the structure, the who gets to teach what, is just such a nightmare. It's all about, um, you know, the professor, the role,
Control,
the territory, control,
right? Really tedious.
and nothing about, student learning.
So you head off to the Bahamas, high, wide, and handsome, to work with one of the best people in medical education, and you get to own the 5th semester, and you just basically did the program, right?
Got it. And basically over the 5 years leading up to that point, we had been working together and I had been, developing my skills with your approach to, how to really think like a doctor and think deeply and in a really organized way about the underlying principles that drive, medicine and learning medicine.
Just to interrupt for a sec, one of the programs we got to do was with a medical school in Mexico, and they asked us to take their subject-based learning, and they gave us the evening and said, "Why don't you show why they're learning that for clinical medicine?"
Correct.
And you and Ben Doonan did that for a whole year, remember that?
We did.
I think how much you learned just taking their basic sciences week and saying, "Let me make you care."
And it was really great. The students loved it. They could really see how just taking they could just see how this mattered to a patient. The feedback was just incredible, and I think it was because, well, it was just such a new way of thinking about it that seems so obvious once you hear it, but when you're in that classroom pounding your head against the table, trying to learn factoids about, you know, disparate
Yeah, you hardly know what to pick there, so it's all those factors.
it's just you don't even know where you're going,
Correct.
Um, so that it was these kind of experiences that not only hone your skills as an educator and really you can just anticipate the questions the students are going to have ahead of time, and really develop you as a teacher, but also just you know time and again just show how successful this approach is from the student perspective.
Okay, so now you get to run the semester. It's just you. How did that feel?
Yeah, I mean, I think it was, exciting, nerve-wracking, this anticipation of a lot of sort of expectation and pressure.
So let me just review that for our audience. This is a brand new medical school. This is their inaugural class. These are not students that are good test takers. And there's nothing in the first 4 semesters that's reassuring that the step exam is going to go well. So you've promised the world this is magic, and then they give you a very challenging group of students to work with and said, "Okay, Mr. Smarty Pants, show us."
Yeah, and I mean, all of these groups are a bit challenging, right? This is the student population that you work with.
They're not great test takers. It's nothing wrong with the character, the skill, the intelligence. By definition, they're just not great test takers, and they got this all in step 1 exam.
And that's the rub. It's all in, right? You've gotta be prepared for an exam that is a very challenging exam. And here it comes. This is the prep for taking the test, and walking them through, basically each of these organ systems using, the approach that you've developed that we, worked together on for so long. You know, it really, I think, showed them a way of thinking about the medicine, the questions that they're gonna need to answer on this test, and to do it in a way that's focused and efficient, and that's, I think, one of the big challenge of our students. The test is challenging. It's particularly challenging when you have to answer these questions in 60 or 90 seconds. I mean, you have to have a focused grasp on this content,
And it's clinical.
and it's very clinical.
You could know every fact in first day. It doesn't let you start with a clinical question.
Correct. You've got to make the diagnosis, straight off the top, and then go back to your, very organized approach of how to think through these disease processes. Again, from patient all the way through to DNA, where you're going to be asked one aspect of that disease process. And I think that's where the power of the program comes in, the power of the approach is, you're not just teaching them individual facts about diseases. It's really an approach to all diseases. How do we think about
Oh,
how
medicine, right?
it's how to learn medicine?
Okay, now you did that for what, 3 years?
I did that for 3 years.
And then as my military kids said, you got OBE'd, overtaken by events.
Overtaken by events.
So you eyed your second breedy, and it was time to head back to civilization.
It was sort of a big personal, component to this, as again, as life happens,
Yes, yes, with 4 kids, I'm very familiar.
Very well know, yeah.
Okay, so but this is really different, right? Because now you're leaving extraordinarily successful professional achievement. Do you think anyone else in the world has ever done this like what you did with that group?
I don't know that
But
that
it was pretty impressive.
we were all very proud, I'll put it that way.
Weren't we proud and gratified? We were so happy for the students. They all passed step 1, every one of them.
Yeah, or at least they've made it, to that level where they're
Well, everyone that did the course and passed their screening exam, comp exam, every one of those went on to pass step 1.
yeah, and I think that's pretty much all of you know,
Yeah, it was so impressive.
which was so impressive.
Now comes the magic whole point of this interview. You're heading back home into practice.
Yeah.
What did it feel like the first day you put on the white coat and you walk into clinic? What did that feel like?
You're like, "I'm back," you know? Um, again, similar feelings, nerve-wracking, trying to get the rhythm and flow of the of that, different hat you're wearing. And it is a very different hat. It's one thing to lay out, heart failure. It's another thing to find it in one of those rooms for the first time, figure out that is what's going on, and what are you going to do about it?
It wasn't a sim patient this time, was it?
No, it wasn't a sim patient this time. Exactly. So, there's that level of anxiety when you walk in a room and somebody's sick, I mean, and that's always, I think, there. I mean, it's not just a new thing. It's just,
No. I never did a frozen section my heart wasn't a little bit accelerated.
there you go. I think that's one of the beauties of this job is it's intense.
So you're taking 10 years of teaching comprehensive medicine pathophys, and now you're back in patient care. Tell us about the experience.
Yeah, it just all those memories come flooding back of, patients you've had and, being in the office and the hustle and bustle. Academic life is intense, but it's a bit calmer intense. It's a reading intense. It's a thinking intense, and clinical practice is a lot more on your feet, boom, boom, boom intense, and seeing patients, just brought back that, again, just so special feeling and of just taking care of people, which is wonderful. And also just that mental challenge of really loving to figure out these sort of human puzzles. What's actually happening? Do I have it right?
Now, tell us that experience in the context of someone who has taught pathophys for 10 years. Tell us about what it was like now that you bring that profound understanding into patient care. How are you as a doctor having done that?
Yeah, I think it wasn't long before I realized, Philip, it's all failure. It's all failure. So all of those sessions that we did, it's just so powerful. You are constantly thinking about, um, kidney, uh, pancreatic islet beta cell, myocyte, alveolar. I mean, you're just thinking about those things in a way I did not before as a physician. Not in as complete of a story as we talk about, when we're teaching.
Has it made you a better doctor, do you think?
Oh, it absolutely makes you a better doctor. And it's constant. It's every day. It's thinking about, where is this person's GFR? How many nephrons do they have left? I mean, you're thinking about it you have the picture in your head that we put up on the board so many times in the class, and talking about, diabetes and hypertension and glomerular function, and you're seeing it. You're visualizing those things that we taught, students in the classroom in a way that I just don't think I just didn't have the picture in the same way that I do now when I, was a resident, for example, at first seeing patients.
Well, I got to tell you, I have this vision of myself as a glorified EMT. I was just a really sophisticated EMT. Not that it wasn't skill, but I'd memorized a lot of patterns. And it wasn't until I started teaching that I realized I would have been a way better doctor if I'd understood why I was doing that.
Yeah. No, totally. Why and really visualizing again, I think that the approach is just it's uh, it's so obvious when you think about it, but you want to think about these diseases in an organ, tissue, cell, ultrastructure, DNA. That's how the diseases happen, and being able to think and see that picture in the person in front of you just takes your focus to another level, I think.
When you're doing diabetes, early diabetes, and you get your albumin creatinine ratio, do you actually kind of see the basement membrane filling up with advanced glycosylated end products?
It's exactly what it's literally what you're doing.
You can't not, right?
You can't not. You can't. That's exactly the way to say it. It's not just a number on the lab report, which is so often it is. It's an algorithm. It's numbers in an algorithm you're walking through, not a picture of the glomerular basement membrane and, the advanced glycosylated end products damaging, putting holes in that thing, and being able to just this is the other thing, being able to describe these things to patients in a way that's digestible
It really? Does that work?
to a point, obviously.
Oh, but you can tell stories.
I think having done this for 10 years in a way where you're honing down what is happening, um, it translates to patient care, patient education, So those kind of things, um, y you know, you especially a family practice job, you're teaching patients all day. You're validating what they've read online, you're explaining things. Again, it's the clinical environment, so it's busy, it's stressful, you're seeing a lot of patients, there's a lot going on. But these are ways to make an impact and to walk out of a room and have the patient go home and really have a better understanding of what's happening in their body. And I think that translates to better patient outcomes. How couldn't it?
Okay, tell me the truth. When you see hypertension, do you in your heart feel a little anxious about those lenticular striate arterioles?
Exactly. Exactly.
It's not just theory, right? You can see that little microaneurysm in the little
You can see it, and when you're getting that, MRI and the radiologist is reporting, hyperdensities, uh, indicating likely chronic ischemic changes, those aren't just words on a page. You're seeing it. You're seeing the picture in your mind.
How much do you love jugular venous distension these days?
I do. Fortunately, I don't see it too often.
But do you see the veins? You don't just look for the bulge anymore, right?
Yeah, exactly.
Yes, and I don't think I ever teach that I don't learn something. So I was teaching diarrhea yesterday, and I always thought one of the most useless discussions I ever had was the mechanism of diarrhea in Vibrio cholera. I mean, not that it's not a historically really important disease, it's still prevalent. But in my mind, I had always memorized, oh, cyclic AMP goes up, because that's always the answer in multiple choice, right? Except that, teaching changes us. When you teach this way, it changes you. And I realized, why have I just got a fact in my head? Why don't I go through and understand what really happens? Okay, hang with me. So we get the cholera toxin, which goes to the receptor that activates my G alpha, and that's why cyclic AMP goes up. Okay, great. But then I asked, because it's us now doing this completely. So what does cyclic AMP have to do with anything? And you know what it acts on? The CFTR channel.
Wow.
Well, wait, it's going to get better. So now it goes to the CFTR channel. Out goes the chloride, sodium, osmotic diarrhea, right?
Totally.
So I'm talking to a student about this, and she asked me this question because we got on the topic of cystic fibrosis. So do they have less severe diarrhea in cholera because they haven't got a working CFTR?
Yeah.
Do you know what the answer is?
Yes, it does.
That's right.
Yeah.
And the whole article, I looked it up because, of course, you're always looking. I looked it up, and the article discussed how, okay, it's really bad for the homozygote little kids, but if you're just a carrier, it probably was a survival advantage. Cholera was that important in the past.
Yeah.
And it was just one of those hair on fire, brain exploding. That's the greatest thing I've learned all day.
Yeah. It's like malaria and sickle cell.
Right. Right. So I've been teaching that disease for over a decade without that really good story in my head.
Yeah. And now you can't forget it.
But no, I'll never forget it. Yeah. So tell me a good disease you've seen recently that you went, God, I'm smart. I just love it. I'm so smart because I've taught this. What have you seen recently that gave you a wonderful, good for me story? You can think about it while we talk.
Even yesterday, I mean, the MRIs from yesterday, I mean,
Yeah.
the subtle mental sort of what would seem like a vascular dementia type of picture, and stepwise type of regression that happened pretty rapidly. Obviously, it's a sort of older person, and you're wondering if the story was as rapid as it seems to be, or if this was a more slowly gradual decline. And you get the MRI and you see hyperdensities.
Walk us through that for our audience.
So, vascular dementia is this, arteriolar.
So you've got a hypertension, not amyloid vasculopathy.
Correct. and you're, looking for those type of changes when you order the scan versus, say, global atrophy, if it was more of an advanced dementia, or, particular potentially ventriculomegaly, say, for example, if it's,
NPH.
yeah, normal pressure hydrocephalus, or, so you're thinking through this process, talking with a family member and a patient, and, you have your suspicions.
You're enjoying looking at the testing because it's all pathophysiologic for you.
Correct.
Didn't you wish you had some of your students to show them and talk them through testing teaches pathophys?
I can't wait till I get students, I can't.
Right? It's just this irresistible urge to say, see that?
Exactly. And explain that, how's that work?
Right. And you bring a totally new brain to the experience.
Yeah, and I think just a different perspective, that again, most students, I do not think are learning this way. I've interacted with a lot of students at many schools, all over the world, really, from Rwanda to California, and there's still sort of stuck, very much. It's changing, but still very much stuck. Well, we say we say we're trying in a discipline-based, siloed thing, because that's what most of us feel comfortable with. We stay in our lane. We don't want to teach outside our lane. Probably for good reasons. We don't want to, say the wrong thing or teach the wrong thing, or but also there's turf war, and
Yeah, it's just why have that unpleasantness and the risk of embarrassing yourself?
that's right, right.
You and I have embarrassed ourselves so often, I'm sort of past it now.
Every day, I mean, it's just a thing, that you just, yeah, don't even flinch at,
So, yesterday, obviously, I was teaching diarrheas, right? And this was my great insight just to show students how, I mean, we'd been doing this for over a decade. This was my experience yesterday. So it was the first time I had a little time to think about it. And so, normally I just do it as a paragraph.
Yeah.
So what I did, I made it an algorithm. And so for the first time, I sort of done acute, chronic, and then I worked out with my diseases. And as I looked at it, I went, I can't believe it. Everything acute is microbiology and chronic is pathology.
Yeah.
And I thought, wow, if our students would just take diarrhea in the GI system, they must be able to do 70% of all the organisms they have to know, all with a good story of how to think about them in acute diarrhea setting.
Yeah.
And I taught it that way, Eric. It was so much better. So I will send you the algorithm and you'll look at it and go, oh my God, it's micropath. What were we doing?
I'm gonna put up on the wall and have the students tell me about diarrhea, and see, let's see how much of the, approach can they get,
Have you had any experiences clinically now you say, oh, I could teach this better now that I'm back reminding myself of patient interactions? Does anything come to mind?
Not really, to be honest.
Oh, we're doing that well, are we?
I think so. Look, to be honest, really think so. I mean, I always talk about, the clinical side. It's the pleasure of working with and helping people. It's sort of that, altruistic thing that flows under all of medicine. You hope, in so many ways. Why so many people get into it. Um, I think the main thing about the clinical and teaching is it's just the street cred, as you say. It's just being able to go from the office right in the classroom and say, I just saw this yesterday. And that's so powerful for a medical student, for any learner to see what they're learning in the context of who they're going to be and where they're going.
Failure is dominating your practice.
Failure is dominating the practice.
So diabetes, hypertension, what else are you seeing that you just got to do all day, every day?
The ramifications of that, heart, kidney. There's a lot of COPD, emphysema, a lot of asthma.
Do you have office PFTs?
I mean, in being able to explain that to patients.
So you have an office hydrometer?
We don't. No, not a pulmonary function test, just a peak flow sort of thing for acute. Well, I think the question is, and then what am I gonna do with it? But, I would love one if I knew how to use it and could you know?
Well, but I mean, I've never looked. We should look that up. How much fun would our students watch you and me figure out which one to order? We'll put it in the office, and then we'll get your patient's permission, and we'll video you teaching yourself to use the cotton pick
It would
advantage.
be amazing.
I mean, I know Allie would say that's the greatest content of all time, but you and I would think that's pretty funny.
Yeah. Yeah.
How about ultrasound? Do you feel like a wanker that you haven't got great ultrasound skills?
Yeah. More and more. Um, more and more, it's just becoming even family practice, you know?
How are you going to teach yourself?
Well, I've got some sports medicine guys upstairs who are all about the ultrasound,
Yeah.
and, they're great guys, and they're avid, teachers. They really wanna spread this knowledge and technology.
Make me a promise.
Yeah. Yeah.
You will keep track of your painful early learning of ultrasound so we can all let our students know we're all useless. Don't ever apologize for being ignorant. Just apologize for not getting better.
Yeah, that's the point, right?
So keep track of that learning phase of what it's like to be useless.
It's learning, you feel very useless. I mean, you feel like you're
That's right. You're
you're
boning.
Yeah, exactly.
You say stupid, obvious things, right?
It's called learning, I
Yeah.
mean, you know.
Give your phone when you first pick up that ultrasound and they say, please put it there. Get someone to pick up your phone and you go, where? And they give you the look, well, there, you idiot.
Can't you see that right in front of your face? You're not measuring the median nerve in the carpal tunnel, you're measuring, the extensor tendon. What's wrong with you? Yeah, yeah.
Our students need to understand how that's all. Don't let that stop you from getting better.
Yeah, it's a huge hurdle for many of our students, especially the students we teach. They've been beaten down by these exams for a long time, and confidence is a huge piece of doing well, in medicine in general, but in these exams in particular. The pace of the exam, it just you know feeds on your confidence, and the minute that starts to slip, I see it over and over with students. The scores just go down.
It's a death spiral, isn't it?
It's a death spiral. Even though the students know the content, they know the right answer. They get into that test and they just
They start to doubt,
they just start to doubt.
anxiety, and then the fog.
It just crushes them.
And the one good thing I've always believed about what we do is, I mean, after 2 years, how could 42 hours of review help at all? Except that it tells you there's a plan. And so when you practice that plan, when you feel that anxiety and the fog, you go, no, let's go back to basics. Age, gender, time frame, find the chief complaint. What's the difference? It gives you a tool for that sense of inadequacy.
Absolutely. You have an approach, and I think the more students just have that just drilled in, they go up to the board, they draw the picture, they explain and talk it out. Um, that's the answer is there, and that's going to be one of the multiple choice answers. They just have to have the confidence to pick it.
You know what? I have the biggest trouble convincing students that the best way to get ready for your exam is to get ready to be a good doctor. So when I say to you, here's our program, do you use it every day in your patient care?
Every patient in the patient care. I mean, you know, basically every patient. I mean, sprained ankles and stuff I see quite a bit. That not necessarily a ton of uh, patient to DNA in that encounter. Uh, yeah, it's more anatomy and inflammation, and I mean, there are some key principles there still, but every other patient, every chronic disease management patient, which is so many of the patients I see, it's not even just one thing, it's multiple things. It's you
Yes.
know 5 or 6 of the core disease principles we've talked about in let's say a review course or um, whatever are in that patient.
Where do you see this going? Right now, you've got a really young family. You've got, it's just a work part of your life. You've got a nice job where you want to live. Where do you go from here?
Yeah, it's a great question. I think I haven't let myself go there yet.
Well, it's pretty new. I mean, how long you been back in practice? 3 or 4 months?
I mean, yeah, 3 months, first of the year.
Just for the audience sake, you should understand, Eric and I lived together through all these teaching programs, so you're watching us catch up on each other. It's like
Yeah,
an old thread that you've missed, so a lot of this is us catching up.
yeah. So just 3 months. You know, I obviously I gotta get students into the office. That's sort of the next big step, and I think, come the start of the school year in August, I'll be settled enough and, I'll get a student into the office at least, you know, once a week or whatever the rotations, work out.
Well, obviously what I'm excited by is I want you to come and work in our new website. So, you can see that you bringing this to our place of I've taken our teaching to practice. And now I'm going to tell you about my experience with students in the office. I'm really excited. I wish Ali would get on with getting our website going because I think that that's something that everyone really wants to hear is now transitioning from basic sciences classroom to you teaching it in clerkship.
Yeah, it does feel like, the next step, at least for me in my teaching development.
Well, we've always wanted to take this into clerkship.
Yeah. We know so much of the learning of a medical student happens in that 3rd year. Um, the first 2, so many students just memorize crap and blow it off.
First aid in your world.
First aid, pass the test. When I get to the hospital, then I'll really learn stuff. This is in the mind of a medical student. And then they get there and they're floored. The 3rd year is a big year.
Sounds like then we should catch up with you this fall.
I would love to catch up this fall.
You got to do us the joy of as best you can recording learning ultrasound and you being the new guy.
I I will do that. We'll say,
Okay.
turn it from the other way. It's upside down. That kind of moment. Yeah, yeah,
Other left, right?
yeah. Exactly, exactly.
Okay, well, this has been great. I hope that the recording's gone all successfully with Ali. Um, we'll be in touch and no later than this fall.
Yeah, sounds perfect. I'll capture that video.
Best to your family.
Thanks, Philip. See ya.
Bye bye. If you are a medical student and you want to learn medicine from your patient centered doctor's perspective, here are things you must do. First, if you want the whole universe of my thinking, you can get the textbook. Click the link in the description. Second, if you enjoy the podcast, you can go see my earlier podcast with Dr. Selfridge. See you next time.